Claire is a postdoctoral fellow at the transitioning Yale Center for Medical Informatics. She is the creator and sole author of the first LGBTQIA+ controlled vocabulary for usage in healthcare settings, the gender, sex, and sexual orientation GSSO ontology, which contains information on more than 15,000 terms. Dr. Kronk has provided valuable input on the GSSO standards for a number of organizations, including including the HL7 Gender Harmony Project, the Systemized Nomenclature of Medicine, and the Canada Health Infoway, CHI, the Organizational for Standardization ISO, Queensland Health, the National Academies of Sciences, Engineering and Medicine, the United States Core Data for Interoperability, the World Health Organization, the Trans Metadata Collective, the Homosaurus Wikidata, and the American Medical Informatics Association Diversity, Equity, Inclusion Task Force. So needless to say, we are thrilled and very lucky to have her here. Claire, I'll let you take it away.
I'm so sorry I gave you such a long list of names to read. I completely forgot that I did that.
So fine. I'm sorry I stumbled on them.
Oh, no, you're fine. Hello, everyone. It's great to be here. So I'm here today presenting on standardizing the unstandardizable, talking specifically about the case of sex and gender and existing and potential future standards as they currently exist across the healthcare landscape, as well as diving a little bit into the research side of things outside of healthcare practice. So I do want to provide a couple content warnings. There are some things that I'm going to be discussing that some people might not want to hear about, which is totally understandable. This is going to be like frank discussions of transphobia and intersexphobia in healthcare. Additionally, some of the language that is referenced or talked about in these standards is outdated. Much of it is considered pejorative. And I totally understand if that's not something that you want to engage with or be here for. And if that's the case, I do not recommend listening to the rest of this presentation. And it will be a few slides before I get to that. But if you do want to leave, I totally understand. So in terms of our agenda today, basically what I'm going to be talking about is more of an introductory idea of what sex and gender and standards look like from a basis of what are standards, how do they come about, and how did this specifically happen for sex and gender standards, as well as philosophies that underlie my specific approach for sex and gender standards, as well as others' approaches for standards generally. We're going to be talking about understanding the fundamental constructs of sex and gender and how they relate to standards and how knowing those constructs can help in building standards. And we're going to look at some current approaches and critique them a little bit. And we're going to look at what's upcoming, the path forward, and see if we can draw any conclusions. A lot of this work is currently ongoing, and some of these discussions that I have might be out of date, honestly, within hours. It's kind of depends on a number of factors here, but I hope it will be useful nonetheless. So I've already kind of gone over this. I did recently take a new position, so I'm now working on controlled vocabulary development at JPMorgan Chase, but I am still finalizing a lot of the standards work. So a lot of the standards work that I was doing is becoming open. So if you would like to be involved in any capacity, you can always let me know. My Yale email still works, and I would be happy to introduce you or give you a primer on any of these standards that I have worked on or are continuing to work on. So in terms of learning objectives, we're going to be looking at how we use standards in healthcare systems in relationship to sex and gender. How do they come to exist as standards? And what do standards currently look like? And what should they look like or could they look like in the future? So I like to start with some of the worst ones I've ever seen. There are some that I have seen recently that are even worse than these, although I have to say my current favorite is still male-female Venezuela. I have also seen one recently for a veterinary app that was male-female spade, which is very interesting to me because I don't know if we really consider that a gender determination because it's animals and it's not really a sex determination either, but it's interesting to consider how different environments might consider this variable completely differently, even if they call it the same thing. So looking at how EHRs use standards, these are on a bunch of different levels, be it semantic, structural, syntactic, or system-wide. These are built on a number of enabling standards and recommendations that have come across or come up very organically. So EHRs were not really ever planned releases up until extremely recently. So when we're talking from the time period from the 1950s to about the 1980s or 1990s, any electronic health information that existed or was exchanged during that period generally relied on rules of thumb rather than any sort of, well, do this or that. Health Level 7 came about, in the 70s with kind of its first idea of what to do. But it itself was built on pre-existing RFCs within the existing ARPANET and internet landscape. And so it was also somewhat ambiguous, confusing, and difficult to implement in its original version 0, so to speak. Something to keep in mind is that a lot of EHR systems are created by for-profit corporations, and they compete for contracts and data. So, for instance, Epic and Cerner might be going at each other constantly for these things, but we have to kind of think, okay, if I had a lightning port or a lightning charger for my iPhone, Apple makes those products specifically so that you can't move over your accessories from Apple to Android. And so that makes it very difficult for an established iPhone user or Apple user to switch any of their systems over because you have to buy all this new stuff. EHRs, when left unregulated, attempt to operate in the same way and to make interoperability impossible. Usually, interoperability has to be coaxed by larger organizations, such as billing companies that work with EHR systems, or governments most of the time. So even within that, EHRs are products, and as such, customization is considered kind of the name of the game and being able to sell EHRs as a product. And so you might have 2 Epic environments in the same hospital and 2 clinics that are right next to each other, and they might not be usable by the other person in a different department because it looks like a completely different system. As well, and this is a particular problem in the United States and Canada, as well as I'm learning Australia, is that different jurisdictions and sub-jurisdictions have different EHR-related policies and requirements, substandards, and laws. So for instance, while we were developing HL7's Gender Harmony Project release, New Jersey passed a law that was in conflict with California's existing law. And so 2 different substandards had to be created for California and New Jersey, and they had to have the ability to roll up into US CDI as required by CFR on a federal level. So this caused a whole jumble of a mess, as you can imagine. So what kind of standards exist? There are tons of them. I think everybody here has probably seen all of these, or at least some of them. We're going to talk about a few of these later, but this is just to showcase that there's a wide variety of usage for standards, and sex and gender touches all of these in different ways. But the one we're not going to be discussing very much today are privacy and security standards, although if you're working within the EU, it's of note that sex and gender are not considered GDPR protected right now. They may be in the future, but sexual orientation is. And so asking a demographic sexual orientation question in the European Union is currently illegal, unless under express circumstances. So it's something you consider when you're thinking about data collection outside the United States. So how do standards come to exist? In my experience, these are basically the 2 things that happen about 90 to 95% of the time, depending on your jurisdiction. And that something goes horribly wrong, there's some public outcry. In response, a law is passed. This directs a standards development organization or an SDO to recommend a standard to prevent this from happening again. Then we form a committee that's usually ad hoc of volunteers. These volunteers, over the course of a year, 2 years, 3 years, 5 years, depending on how complicated the standard is, write and refine recommendations, which go to ballot, and there's a whole standard process through the International Standards Organization by how ballots work. But eventually these get passed and then they get implemented. And so in a best case scenario, this can happen really, really quickly. We saw a lot of this with COVID, where it was an emergency. Everybody had to drop everything and just work on COVID standards for a while if they were working on anything that could be transferred to that. And there was a lot of buy-in from corporations to do that, obviously. And so that happened very quickly. There are other standards that have been in active development since 2000 and are still not together, and probably will not be for another 10 years. So it can take a variable amount of time. The second route is really capitalistically focused. So if routines using standards were done differently, then maybe they would make more money. And so they kind of basically hand money to politicians to direct a policy to be created, and then that affects standards creation. The third, very rare or like a shiny third route is basically if you have very opinionated individuals being either out of the kindness of their heart wanting to change how the standards landscape looks, or having ulterior motives. I've seen both. Join any of these volunteer-based organizations to attempt to influence policy in a particular direction. That third route tends to be less successful because ultimately a lot of standards are kind of in debt to existing governments. And so, for instance, I can go to the American version of the systematized nomenclature of medicine, and I can say, well, I think the standard should be this, and they might change it. But what can happen is HHS or any member of Congress can say, well, this is in conflict with the existing CFR or the existing structure that we have, and roll back your changes. So it's kind of you might get one step forward, 5 or 6 steps back occasionally. So that's something to keep in mind if you're going about that route. So how are standards implemented? Badly. I think if anybody remembers ICD-10, nobody was talking about it with, thinking, oh my gosh, this is gonna be so much fun. We're switching to a better new standard. That's gonna be great. Unfortunately, from the technical standpoint tends to be difficult, but it's nowhere near the most difficult. A lot of the problem is that there's no clear guidance on what to do with these new standards. Should we update or keep the same obsoleted standards? Usually they're just kept as is. So I've seen a number of hospitals who try to update everything to ICD-10. Some kept older records in ICD-9. Some updated them only for patients who were still coming in or patients who hadn't been cleared out of the system. But I would say that any of those technical issues could be solved quite relatively easily. The biggest issue is really educational. And so when it comes down to how people are actually using these standards in practice, you end up in a much more difficult situation. So for instance, you might see that a particularly useful code is very, very long. And when you're looking in a list, it comes up as the 50th result. So it's unlikely that physicians are going to click that because it's so low down in the list and requires so much scrolling. So it's just something to consider when these sort of things are put together. So in terms of my philosophy when designing systems or designing constructs for clinical use, I typically follow these 7 principles to the best of my ability. I will say this has kind of been a process of evolution over time. And so I did not necessarily start with these principles day one. Some of these principles are followed very, very loosely. Some of them are followed very strictly. It really depends on the underlying standards philosophy as well. And so like, for instance, SNOMED has a very defined philosophy and people get really into that philosophy. And if you try to change it or try to put something any which way, it's really struck back against. Whereas my experience with HL7 is it's a little bit more fluid in terms of their philosophy on additions and subtractions. So it's my opinion, and these are most of my opinions on, we should align systems with standards that exist where possible in order to be functional. So anything that's not tied to a standard should be tied to a standard. I've seen internal standards really flounder. For instance, I used to work at a hospital that had its own internal drug coding system, which was very bad. And so last I heard, they were beginning a multi-year effort to move that over to a larger standard system. And so hopefully it'll be more functional when making referrals at that point. We need systems that align with patient care needs. We need them to be usable and understandable to clinicians. It's not useful if nobody can understand it and nobody knows how to use it. And this is one that researchers really don't like, in my experience, which is that systems should be designed for individual care first, everything else second. And so this has a lot to do with international health law and individual jurisdictional health law, and especially when we're designing global health standards or international health standards. So for instance, you can't ask questions in the GDPR simply to know the answers to them or to collect surveillance data just because. There has to be some level that it's helping that individual patient. This is implemented in some respect in US standards as well, but not to as strict of a degree. And so for instance, people will ask, well, I think this would be really useful for a population health study. And we really have to sit there and say, well, okay, well, how is it helping the individual patient that you are collecting this data from? And if we can't get an answer from that, usually it doesn't end up getting implemented. This is one that I work from a lot. This is not something that most standards operate from and that no implementers operate from in my experience, which is designing for the most vulnerable patients, not the most privileged. So most systems, and I will say that my experience in standards groups has been, oh, well, we cover 90% of the population. That's fine. It's only 1% or 5% or 3% of the population who goes through this. Who cares? Like, you know, I get that a lot. Those are quotes from people, not just my expression of those philosophies, but they're very common in my experience. And so arguing for protecting vulnerable patients is really not something that has been successful in my experience in standards, but it's something that I think we should advocate for more and more. So for instance, if I have Mount Sinai, one of the largest hospital systems in New York and one of the largest cities in the world, has a decent amount of money, a decent amount of resources, very good care teams, versus care teams that are set up in, say, rural Oklahoma, rural Alberta, in former Eastern Bloc European countries that are still being rebuilt in many areas, in Ukraine, in places that are war-torn or disasters have hit. You have to have systems in place that can deal with, we don't have any electricity. How do I, bring a patient into my system if there's no electricity? And this was a huge problem in Japan following the last nuclear meltdown that had happened there, where people had to be entered into the hospital system and were getting lost because no physicians knew how to use the paper systems that were in place anymore. And so that's something that had to be really put together as well. We might have an MRI machine that's 30 years old, and we have to be backwards compatible with that. Or we might have patients who can't really access MRIs at all if they need them. As well, having a baseline level of respect for patients represented by data, like these are people, these are not rows in your spreadsheet. These are data representations of real life human beings with their own thoughts, experiences, and lives, and they really need to be considered as such and not just as another row in a spreadsheet. And then finally, we have to take into account the current state. We might not like the current state. We might very much dislike the current state, but if your system can't be added easily in, then it's useless. Nobody's going to put it in. Nobody's going to want to do it. Implementers are going to be disincentivized to do it. Governments are going to be disincentivized to adopt it. And so effectively, you've just added bloat to the system instead of something that's useful. As well, and these are kind of my additional linguistic considerations, a lot of standards are built with this idea of if this should be a standard that holds for a very long time. That almost never happens in practice. But for instance, whenever I talk to DICOM, they're like, well, we want something that's going to be working exactly the same way in 50 years. In 2070, they should be using the exact same DICOM system that they're using today. And I'm like, that's very ambitious to say that where life is going to be in a half century. But at the very least, I think 5 years, 10 years, 15 years, 20 years should be thought about, and how much terminology can change in that amount of time. So prioritizing terminology which is consistent, understandable, translatable into a number of different languages. I get pushed back on this a lot. Like, hey, I don't think we should use this word because it doesn't actually translate semantically in the same way. So for instance, age terms, like girl, boy, man, woman, etc., do not translate one-to-one in most languages, wherein age-based separators that are gendered might either not exist or exist in different ways. And so we kind of want to avoid those things because they're not alignable between different languages. Only create new terms as an absolute last resort if something exists in literature which has not yet been adopted but shows an increase in adoption. That can be a good idea, but that also has to have an asterisk applied to it because if nobody knows what it means, it might not be usable. This is really important to me because I see a lot of survey researchers, this next one, will want to take something that worked really, really well in a survey that they did and put it into the electronic health record, is that oftentimes questions and answers might not match one another. And so the question might be something along the lines of, what is your gender? But then is coded as gender identity. And so the question wasn't, what is your gender identity? It was, what is your gender? And so although you might say, well, that makes sense to me, those are the same thing. In reality, you're kind of hiding something from the person that you're asking the question to, right? You're not being completely open with the patient about how this is being coded, what it's being coded as. And so the question and the answer are not matching in this case because you're asking a different question or you're meaning to ask a different question. And then consider clarifying terms sparingly. I do see some standards where people want to add 40, 50, 60 words in a single string for a drop-down select, where it's going to take 5 minutes for somebody to read the 3,000 options that are going down. And so clarifying terms can be very helpful, especially when translation might be difficult. So for instance, not all languages have a sex gender distinction. And so saying assigned sex or assigned gender at birth might help regardless of where it's being translated as, because the extra contents of assigned at birth might give more context to where this datum is being created or how it's being created. So let's move on to kind of understanding these constructs of sex and gender. So this is how the World Health Organization currently defines these terms. These are kind of simplistic definitions, or classical constructs, as I call them, because the simplicity of this kind of distinction has been around in the English lexicon for about 60 years now, but is just now becoming like the mainstream version. However, we've known for a very long time that this is really an oversimplification of reality, that things are rarely as simple as, well, this is biological and this is not biological, or this is social and this is not social. We kind of mix these constructs together all the time. They fuse into each other and come out of each other all the time. They might be different for different people at the same time. It can be very difficult to know what's being referred to. So if I say sex with no clarification, you have really no idea if I mean any of these things, all of these things, some of these things. It really depends on the situation, which can cause mistranslation and miscommunication. So when we're talking in healthcare, though, we typically try to build out from use cases. And so when I worked with the HL7 Gender Harmony Project, this was kind of how we built it out. Use cases was considering something that was happening in a hospital or clinic, and how or where would the provider look in order to figure out what to do with that information. So, do I assign this patient a male or female shared room if those are the only two options available? Well, where do I pull from? What do I look at to do that? With what do I put on a birth or death certificate? This gets really difficult. And for instance, there's an organization called the Trans Doe Task Force, because a lot of trans and intersex people actually get lost after death and become does, because they might not have had documentation on them, and they might have gotten their gender misclassified in a death certificate or other record. And it might be months or years before family members know that that person has died. And that has happened multiple times. So the Trans Doe Project has something like 150 cases in the United States under their belt where something like that has happened. And I think the longest case, it took 5 years to find family members, and they lived less than a mile away. So it can be really, really difficult when these things are entered incorrectly. So talking in animal research, because this is something that's been coming up recently. So sexing is kind of the way that most researchers and scientists look at non-human organisms or non-human animals specifically. And this uses telltale characteristics in the same way that assigned gender at birth is put together in humans most of the time. But the wide variety of characteristics and the fact that sometimes they can be very difficult to assume or observe means that misclassification rates for different organisms can be completely different. And there's no translation between this. Most of the time, there's no genetic determination or gamete collection of any kind. So I used to sex Drosophila when I was an undergrad, and we did that by weight. And so we had a misclassification rate of about 5%, which was considered acceptable at the time. I don't know if that's still the case in Drosophila research, but it's something to consider is that each one of these things, sexing mechanisms has a different error rate, a different rate of, it can't necessarily be compared between species very easily. And so it's not translatable as well to any particular other species. As well, some organisms that are non-animal might have completely different sex systems that are not anesogamous. And so that might require an entirely different set of standards being put together. So for instance, for nematodes. Typically, animals are not considered to have gender in any form. Theoretically, some aspects of animal social behavior could be analyzed in relationship to gender roles or psychosocial behavior. But most of the time I've seen these comparisons, they're fraught with methodological and bioessentialist assumptions that make them difficult to rely on. So usually I don't recommend doing so. And the literature doesn't necessarily recommend that either. In these cases, the best thing you can do is be clear, like, what was your sexing mechanism? How did you put it together? Why are you trying to compare it? How are you trying to compare it? For instance, if you're trying to sex lions, we probably would not do it the same way that we sex Drosophila. We would not do that by weight. It would be extremely difficult to undertake. So where do sex and gender standards appear in electronic health records? In short, everywhere. I really honestly hope that after this presentation, whenever you're working with electronic health record data, you look and see how many times a sex or gender variable appears. I'm guaranteeing you in a typical day, you'll probably see it anywhere from like 50 to 3,000 times, depending on your area of practice. I have seen some of the craziest things. For instance, trans men putting in for abdominal screening, where we get back a result of sex was male, prostate looks normal, where there is no prostate whatsoever, which can be very confusing and could cause delayed care pathways. I get an example of that maybe once a week from a physician. And so in terms of what purpose these standards themselves serve is kind of an open question. The very, very short answer is that they provide a relatively simple proxy to a number of data elements considered medically relevant, asterisk most of the time. So that's kind of that, well, it works for 90% of patients, so why should I care? The issue is that, you know, oh, okay, the provider now has to ask fewer uncomfortable questions, and they get to like enforce a strict medical binary, which relies on default assumptions about male and female bodies, as well as all other bodies that exist outside of that binary. And so this is bad both for people within the binary and outside the binary, because it's moving away from personalized healthcare and building these kind of ideal models. I also see kind of gender diversity in other countries being relabeled in a way that's more understandable. So for instance, Indian physicians I've talked to have often said, well, oh, Hijra are the same as transgender people, and they all have gender identity disorder because that's the mental disorder that they have. Even though Hijra has existed as an identity for hundreds of years before transgender people really were calling themselves transgender, this has been rewritten just because the DSM has been essentially exported to these countries. So how has this impacted trans, intersex, and gender diverse care? In short, very badly. It could be better in a lot of different ways. So importantly, this prevents certain procedures and diagnostic codes from being applied when a particular administrative gender is in the record. So oftentimes doctors that I know have to switch the entire record from male to female and then back to male, maybe 5-10 times a day, depending on how many things they're trying to put in and get cleared. A lot of things are blocked automatically if you try to put them in terms of procedures and diagnostic codes. I've seen blocking of certain pharmaceuticals from being prescribed and misdosing of other people. For instance, using wrong reference ranges or growth charts when considering dosage. I've had people who have gone to pick up prescriptions that went through, and then the pharmacist doesn't believe that they should get that prescription, and so withholds that prescription. We put people into wrong gender specific facilities, dead name, misgender, verbally harass, forced outing. I've seen the whole gambit. And recently for the International Standards Organization, I put together a worldwide review of firsthand experiences of trans and intersex and gender diverse people on healthcare experiences. And so this is kind of why I put the content warning at the beginning, because these are some of the experiences that people are going through. And I will say that these are not even some of the worst that I have seen. This is kind of top of the iceberg level. Things get much, much worse. If you want to read that report, it includes over 500 quotes like this from almost every country in the world. But a lot of issues were providers simply refusing care, calling the police, acting as forces of imprisonment, forcibly sexually assaulting or physically assaulting, leaving people to bleed out, withholding care unless individuals had sex with the provider. There were a number of really horrible situations, a lot of gaslighting of intersex people, telling them that it was their own fault, that something had gone wrong in their care. And it's a really horrible situation. So I just want to kind of leave a little bit of that there for this idea of, what is actually happening on the floor is very different from how standards development organizations I've worked with actually engage with standards. So for instance, I was working with a standards organization, and we were adding a different option that would allow more expansive reference range usage. And one person who worked in a lab and on the lab standard basically said, well, that sounds annoying. I don't want to use that. And that's not going to work for me because it's just like, I don't want to use that. I have a system and it's fine. Why are we changing this anyway? And I said, hey, this can lead to this and this can lead to death. And the response I got was, well, you're being too harsh on her. Like, how dare you say that? You should never mention, what could happen with our standards. So the culture can be sometimes relatively toxic in that regard of not mentioning the consequences of how standards actually affect people. And honestly, it's one thing that I disliked the most. So when I was writing the ISO report, I wanted to make sure that was front and center, so it could not be avoided by voters on that ballot. So in one potential case, let's say you're using the current US CDI standard and you see the term transgender male. And I will tell you, I've seen publications, I've seen electronic health records where each one of these different interpretations has gone through and completely messed up the care pathway. In that the wrong thing was done, the wrong test was ordered, the wrong reference range was used. And in some cases, people did die in this situation. There was a recent, not editorial, but viewpoint that was in the Lancet, I believe, or no, New England Journal of Medicine, that had a trans man who was entered as male. And so the nurse did not know that he was pregnant, or did not consider that he could be pregnant, and that almost resulted in a miscarriage. And so something to consider. We have to walk outside of our assumptions, especially when it comes, for instance, to how we teach informatics, because I see this in every intro informatics course, in the textbooks, in the teaching, where somebody's like, well, what's a common way to determine error rate or misclicks in a system? And people will immediately say, well, look for all of the people who are male, who are labeled as pregnant. It's always the same thing. I have been asked on several occasions, well, if we don't do that, what should we do? Which is always an interesting question to me, because I don't quite have an ideal answer for that, but I also know that this is not the way to go about it, because that's not a good way to determine misclassification rate, because trans men can become pregnant, intersex men can often become pregnant. And so in assuming this kind of cisgender non-intersex system is not giving you accurate information to begin with. So just food for thought. So when we think about, okay, well, what happens if I use this wrong reference range? What could possibly happen? And so this is a really, really short list of a few very common markers that are utilized and what can happen if you use the wrong reference range. Usually the couple that are talked about the most in literature right now are hematocrit and hemoglobin. I've also seen troponin 1 talked a lot about in the United Kingdom and Australia, but not as much in the United States. Creatinine is something that's very highly looked at in trans people, specifically on hormone replacement therapy. So that's something to consider as well. But when people look at this, they're like, okay, well, should I use assigned gender birth, or should I use gender identity, or should I use a secret third thing like a biological sex? And the answer is, it's a little bit more complicated than that, unfortunately, because we have to look at kind of duration of hormones, what kinds of hormones or hormone combinations, other conditions that might be present, such as if a person is menstruating or not, or pregnant or not. And these can get kind of complicated in systems to think about. But the big takeaway here is clinical decision-making cannot be made solely on gender identity or assigned gender at birth. Doing so can cause irreparable harm or even death. And this is something when I presented to the National Academy of Sciences, Engineering, Medicine, that I stuck on the slide for 45 seconds because I was like, I really, really, really want to get this across. It's not as simple as asking a certain number of questions and getting a certain number of answers. There are a lot of different things you have to keep in mind. And this care is complicated for everybody, not just trans or intersex or gender diverse people. It's important to think about. So when we look at the current state in EHR systems, nearly all interpretation and all reports, applications, referrals, et cetera, uses a single administrative sex variable. And this appears in the demographic section. If you're very lucky and your vendor and your institution and your jurisdiction and your government allow you to have other information, it's usually placed in social history, which I find very funny because how it is coded as an observation puts it on the same level as, do you smoke tobacco? Which is kind of infantilizing of people's identities, in my opinion. And it kind of implies that this is something that is observed by the provider. Even if it is asked as a question, it's just generally odd. I have seen so much pushback from moving it to demographics, but generally it's my opinion that it should be moved to demographic and treated like any other demographic for a number of reasons, not the least of which being that it can impact how diagnostics and procedures are made in negative ways. So for instance, some systems I've seen, hospitals have written in rules that if a person is labeled with a sexual orientation other than heterosexual, that it immediately adds a high-risk sexual behavior to the account. And that can influence insurance costs. So one, that's horribly discriminatory. But it is currently not illegal to do so. And I've never seen any pushback. In fact, I've usually heard people argue for that. So it's just something to consider, what is being added, how is it being added? So I'm going to talk about a few systems, and I'm going to be very careful not to go over time here. So starting with the consolidated clinical document architecture, this uses a patient gender, but it's actually administrative sex, even though it's called gender. On the back end. So it hides from the clinician and the patient what it is, which is not great. And then when it comes to social history, you get birth sex as the number one, and then way beneath it is sexual orientation and gender identity as a combined field with subfields, which causes a lot of confusion. I see gender identity and sexual orientation confused for this reason. And it's also kind of, once again, infantilizing because it considers that birth sex is somehow more important or more relevant than gender identity, which is often not true, as we've just gone over. In terms of HL7, version 2 was actually getting fairly expansive for the time it was written. This is what it was as of 2.8, I believe. However, it's interesting because 2.1 just started with only male and female, and then people kept complaining and complaining and complaining because they needed more options to function. And all of a sudden, okay, now we have 6 options. But then when V3 came out, everybody complained that there were too many options. So they scaled them down again. I have seen so many people mess up undifferentiated and unknown to effectively make undifferentiated not usable. And now people are complaining again, leading us to the Gender Harmony Project doesn't really exist, but I'll talk about that later. When we talk about USCDI, version 3 draft is currently out, and it's not that different from this. But once again, we have sex assigned at birth and gender identity, both as patient demographics, which is a huge step forward on moving them out of an observation piece. One of the issues that was constantly fought against it was putting sex assigned at birth first. It's always asked first, it's above everything, and gender identity is last. It's also separated from sex assigned at birth, put under sexual orientation, which is generally odd, but the reasoning is so SOGI can be read in order as sexual orientation and gender identity, which is very odd to me, but it is what it is. As well, you'll probably notice gender identity is using a number of very outdated and pejorative terminology. This is in fact scoped from SNOMED and then made worse than SNOMED for some reason, because these terms aren't necessarily in SNOMED how they're written in USCDI. They're written differently, but they're coded to SNOMED. So they get changed to SNOMED when transitioned to systems outside of USCDI, which is in and of itself odd and can cause miscommunication. ICD, everybody knows it. Almost everybody hates it in terms of how it's used in this regard. ICD 9CM and 10CM both use a very pathological and medicalized version of transness and intersexness. They continue to be used, obviously. I'll never forget when I was almost accidentally outed to my parents because they received a bill for 302.5 transsexualism without my consent, which is something people have to consider. You know, when you tie an identity to a diagnostic code or procedure code, you can out people more often and make them susceptible to additional harms. So it's not something that's often thought about, and people are like, oh, well, it's insurance, so it's not technically breaching HIPAA, but it is, and it is something that you should consider whenever you're selecting a diagnosis, even if it is required by an insurance company. When it comes to CPT or HCPCS, a lot of the things that are in here are kind of odd. So clitoroplasty for intersex state isn't that fundamentally different from clitoroplasty generally, but it's separated and there's no idea of how to say what is or isn't intersex state in this condition. It's very odd how trans and intersex identities are treated in CPT and HCPCS, but it can kind of mark how medical procedures are covered or not covered in insurance systems. And so, for instance, a lot of these codes are coded behind the scenes as male or female only. And so if you try to put in a particular code, it might just be auto-rejected, and therefore you wouldn't receive insurance coverage for a procedure. And that can be very, very difficult to deal with for a lot of people. SNOMED is, in my opinion, the absolute worst in terms of the issues related to sex or gender. They have a number of terms which exist nowhere else in literature that I've ever seen. You get 0 results back for a lot of these other than SNOMED itself. Most of these terms are never used at all or relied on at all. So it's unclear why they were added or why they're there because there's no documentation of who added them or why. Many of them are also pathologizing and medicalizing or just plain wrong. And very, very often terms from as early as the 1950s or 60s just keep getting pushed forward without having any reevaluation. So for instance, 7-year itch was something that I had to remove as a disorder term because nobody had realized that it was there. And we'll talk about that process later, but that took years to remove. And then loink is a mess. There are more than 30 now sex or gender terms in loink. It is unclear how they map to each other or relate to each other in any way whatsoever. And it's kind of just generally a mess. I can go into that in more detail if people would like, but these are just a few of the confusing concepts that they have. As well as we can look at development of sex as a biological variable in research. While I think the goals of SABV were initially positive, I think they have kind of nullified over time. So this was meant to be, oh, we need to include women more in research, but now it has basically solely been turned into an anti-intersex and anti-trans research methodology. And it often includes kind of codification of terminology, which is out of date and not inclusive, even though it intends to be inclusive. So this is just something to keep in mind. So you can see a lot of people have written great perspectives pieces, and some have been bad, as you can see the two on the bottom, also by researchers who have kind of said crazy alt-right ideas based on around using sex as biological variable. So looking at the path forward, we have a few different standards that are coming out. The HL7 Gender Harmony Project is kind of the big one. They have 5 properties that they're trying to add. Gender identity, which will essentially replace administrative sex or administrative gender. Recorded sex or gender, which is kind of everything that isn't a gender identity or a sex for clinical use. So for instance, your sex registered with insurance, your gender on your driver's license, etc. Sex for clinical use is tied to specific clinical uses. So it's not tied to people, it's tied to orders, for instance, or procedures or diagnostics. Basically just to kind of streamline the whole situation as it currently exists, while creating as minimal effort as possible for clinicians. So for instance, when making an order for somebody whose all instances of RSG and gender identity match, it would autofill as the same thing, so that it wouldn't create more clicks. And in fact, it would only create less clicks for people who have intersex or trans patients. They don't have to switch the whole record back and forth. And then third person pronoun and name to use are also being moved forward. Third person pronoun, however, is only available currently in English, but they are looking at a Spanish translation soon. ICD-11 has moved to gender incongruence. I think probably the weirdest thing here is that they classify breast as genital anatomy. It still uses a very binary system. Intersex people are still heavily pathologized, medicalized. So while a lot of the pathological language has changed, there's still an underlying bioessentialist model that's relied on at ICD-11. And I don't think we'll be seeing a switch to ICD-11 anytime soon. So it'll be interesting to see what even goes forward from here. With SNOMED had siloed for a very long time any sex or gender related discussions into the mental and behavioral health clinical reference group. So most of the time when I was trying to make better trans related or sex and gender related language, I was siloed into talking to psychiatrists, which was not great. But eventually they said, okay, we're going to do a sex and gender clinical project group. Once I joined, I realized that they had not vetted any of the members, and they had added 2 individuals, one who runs a large conversion therapy business, and the other who is part of a large anti-trans organization in the United Kingdom. So when we brought this up, they shut down the system very quickly with no explanation or warning. They refused to answer to their DEI guidelines, which said that they would respond, which was very disheartening. And generally, they've not included much, if anything, to date, saying they're just going to do whatever ISO does, which was not great. This is a very difficult situation, and I don't work as much with SNOMED anymore because of this. ISO is still working on putting out a technical report. This is the 3rd time it's been renamed, actually. It's now ISO CDTR 9143. It's a technical report, so it's just informing the countries what's going on. It's going to be voted on in Japan in January, but unfortunately, Almost nobody on our committee can attend because the costs to participate in ISO are exorbitant. It's very difficult to get peer review on ISO standards because you have to be a member of an SDO to even look at them, really. And they're very, very, very expensive. So while I hope that this ends up being a good technical report, it's really unfortunate that I can't share it with more people as we're building it or drafting it, but hopefully it's good. Hopefully it influences SNOMED in a positive way. And finally, we have the NASM Measuring Sex, Gender, Identity, and Sexual Orientation report, which had some pros and cons. I recently published a piece trying to harmonize this report with the Gender Harmony Project in JAMIA. I'm very proud of that piece. We had to come to a lot of compromise, which I think is good for moving the science forward. When we're going to get to a better place eventually, maybe not immediately. So in general, change is happening slowly but surely. There's a proliferation of standards, and all of these new standards are creating all their own things all over again. So it's unlikely that they will align with one another. Hopefully they do. Hopefully people choose to do so. We can't really be sure about that at this point. Unfortunately, the most affected communities in this situation are not engaged with substantively or at all, which means that these standards, while intending to be inclusive, often either stay the course of non-inclusivity or become worse. There's a lack of provider education, and there's large potential for mistreatment, even if we get the best possible standards. If they're released in a way that allows for discrimination to happen, it will happen. And so this is kind of the largest problem, is we can make the best standards in the world, but if they're used in a way that's negative, then you've added a general negative, and they should have been kept how is, even if they are bad. So these are really considerations for the whole standards landscape as it moves forward for sex and gender.
Other things so that they can have the time that they.
Oh, I'm sorry, was there a question? Well, regardless, thank you all so much for listening to me ramble about that for approximately an hour. I can stay on a little bit past if people have questions. I wanted to give more time for questions, but there were a couple of points I really wanted to make sure I hammered in. You can also email me at that email or my personal email moving forward, which is clair.kronk@gmail.com. And I'm happy to answer any questions if anybody would be interested in any segment of that future work moving forward. So thank you so much.
Thank you so much, Claire. Do we have any questions from the audience? Adrian?
Hello. Thank you so much for your talk. It was wonderful to hear kind of some key takeaways and culmination of your work with this really important ontology. I have two questions. One is about how you talked about designing for the most vulnerable people, not the most privileged. And I'm wondering about how do we advocate for that kind of cultural competency in our science and research and industry, like when the kind of motivations are not aligned necessarily. And then my other question is about how researchers, you talked about how the things should always be aligned to a standard and that makes them more functional. Do you have any tools or resources for us in our own work? I work with patient-generated data, self-tracked data. So like, how would somebody like me go about harmonizing and standardizing so that my work could be more functional and attached to standards?
Both great questions, and also great to see you. So for the first question, I'm really sorry to say that I wish I had a better answer. Having tried to do so for now 6 years has honestly come up with very little. It's been very difficult to advocate for people, and most of the time on a good day, I'd be met with well, that's a nice thought, but it'll never happen. And on the worst days, I'm met with slurs. So your typical day working with a standards development organization as a marginalized person. So, I mean, it would be very rare for me, most of the times I would be the only woman in the room, even. Like it's at that level. And most of the people who work in SEOs are retirees who are very, very opinionated. So there's a lot of pushback and you really got to fight. And I think it would be really helpful to hear from larger organizations, from the National Institutes of Health, from HHS generally, to support younger individuals who are still practicing or practicing research or in clinical practice to get involved in standards writing, because it's a very laborious task and it's usually not compensated in any way. So, if I say, hey, I think we should do a research study on X before we implement it, usually what happens is, well, our timeline is too short, we can't do that. And so we're just going to put whatever our opinionated thoughts are out into the world. Occasionally we do get better stuff than that, but it's really going to take some larger, probably governmental organizations making big steps to make that happen, in my opinion. On your second point, there are a lot of great and wonderful ontology tools that can help you code particular things. So the NCBO bioportal is a great tool, as well as OntoB, which is the OBO Foundry's ontology collection tool. And then there's also in the European Union, ENBL EBI's OLS, or ontology lookup search tool. These can all help you find different ontologies across a number of different media. Not every publication of an ontology is required to be published in one of these repositories. And so many times single-use ontologies just kind of never go anywhere. This is specifically what motivated my doctoral thesis, was when I looked at how bad the sex and gender and sexual orientation related ontologies were. And so that's what resulted in the GSSO. So it might be that you look for something specific and it's not there. And then congratulations, you have a new research project just for you. And I love ontology and vocabulary development, but it's definitely not for everyone. So it is something to consider potentially as a career pathway. I think it's very useful. It can just be very difficult to find grants that will support ontology or vocabulary development. They do exist, but it can take a lot of work to produce one, and that work might not be valued in the same way. So, it's always worth talking to people who are more senior, who have very established ontologies. So Dr. Lynn Trimmel is the contact for the disease ontology and several other ontologies. Like, she has done so much work over the last 2 decades. And she's definitely a person who's very amenable to contact, or I can put you in contact if you'd like to start designing your own ontologies.
All
Great
right, we have time
questions.
for 2 more questions, I think. So let's start with Yilu and then Undina.
Hi, thank you for this interesting talk. Like when we conduct a retrospective cohort study, we may first analyze the demographic characteristic of the cohort. And in most of the research paper that I read, they only report the sex. Do you think we should also report the gender identity as well, instead of just reporting the sex? I mean, like, from our current data model, it seems to be very hard to get this information. And so what's your suggestion?
Yeah, so probably you are seeing sex as a variable, but are you using EHR data, or is it data that's been coded using another external ontology?
EHR data, like our common data model.
Oh, okay, it's CDM. Okay, so CDM is not great. OMOP has for a very long time also pathologized trans and intersex people by referring to trans people as having gender identity issues, as only allowing coding for male and female. And in my experience, when these issues have been brought up, they've been very not open to change, to say the least. The belief is that because that datum has been translated from the single administrative sex datum. So in 98% of cases, that is gender identity. You're already capturing data gender identity. So it's called sex, but it's not really sex, because most trans people identify their sex in the EHR as their gender identity. So for instance, I'm a trans woman, my sex in my EHR is female. And so if I were in your data set, I would be in your female cohort. And that's my gender identity. So there's already this kind of confusion. OMOP assumes that sex means genetic sex, but does not actually look for any sort of genetic screening of any kind. And so it can also be hugely problematic on that case as well, because it makes assumptions about populations that are not only not there, but often not true. So I really hope OMOP and the CDM move forward, but right now they've really shown an indication that they intend on making their model better. So unfortunately, I don't know if you'll be able to do anything right now because they need to update. It's not really on you, but hopefully they do choose to update in the future.
Claire, I wonder if part of that solution is what you talked about at the AMIA DEI inclusive language, which is just to be really specific about the limitations, like the data that you do have, reporting on what you do have, and being clear about how those two are conflated in the data set, and that being a really transparent way to go about it.
Yeah, Adrian, thank you for bringing it up. That's really good thought. So a lot of times you only have bad data to rely upon. And when that is the case, it can be really great to try to encourage standards to move forward, to give them bad press. So to essentially say, here are the limitations of this data in as many publications as possible, because then that puts it out into the landscape that this change needs to happen. And you have more of a research basis that you can rely upon. And when you're trying to convince people of very different demographic groups from yourself, that this is something that needs to be done, having that long list of publications is often something that helped me push those things forward, for sure.
Claire, since you said you would be willing to stick on for a few more minutes, do you mind if we take the one more question that we have from Indina? Folks, I know that we've hit 1 o'clock, so if you need to drop off, please feel free to. But since we're having a great discussion, I'd love to have this last question.
Yeah, I apologize for going over. That's totally on me. I should have timed my talk better.
Not at all.
Hi, so thank you so much for your talk and all of your work. It's definitely very interesting and very needed, I think. I have a question. So regarding sex and gender and how that's assigned, you discussed like having sex gender assigned and then sex for clinical use. But I was wondering what your thoughts were on like balancing, because you discussed in the beginning having many options, maybe too much for a clinician, but then having too few is also a complaint. So it's like, how do you balance that?
Yeah, that's a great question. A really great question. The short answer is you will never win. It will always be too much for somebody and too little for somebody else. So in my opinion, our suggested implementation for sex for clinical use was not on a patient level, but on an order of procedure level for multiple reasons. The first was to avoid labeling patients in their record so that everybody could see that information. So there was a privacy concern with that. And as, of course, making sure that we're affirming patients and not stigmatizing them further. It was also put there because the same patient can have a different sex for clinical use in different clinical use cases so that providers can change it. The third was to avoid insurance denials. So if you have a trans woman who needs a prostate examination and a breast examination, you can put in both and change the clinical sex, the sex for clinical use for each one. And a lot of people came forward and like, well, can't we just like totally remove ourselves from reference ranges and use organ inventories and genetics and like, just use those. And honestly, through determinations, this goes back to, the most privileged versus the most vulnerable. A large hospital system might be able to make an organ inventory changeover. But in my experience, a lot of the, especially rural institutions we were talking to, were not in a position at this current stage to be able to make that technical switch over. as well, especially in the imaging community, sex for clinical use was not always immediately tieable to an organ. So, okay, you're doing a prostate examination. Does this patient have a prostate? Totally makes sense. Okay, we're irradiating an organ. So we used sex as a clinical variable, sex for clinical use, as a proxy for organ wall depth. It's not very easy nor desirable to cut open a patient to measure how thick that is. So using the proxy is avoiding another thing, but you can't proxy that with an organ necessarily. Does that make sense? So sex for clinical use is kind of, in my opinion, a temporary variable that will hopefully eventually be phased as we're moving away from proxies and more towards, well, what are you actually asking? But I know that's a long answer.
Thank you. That was yeah, no, I think that's definitely sounds good.
All right, I think those are all the questions we have. Thank you so much, Claire, for a fantastic talk and really insightful discussion and sharing of resources here. I think that this is clearly really important work for us to continue embarking on and ensuring that there is an agenda for. And so really appreciate you sort of sharing the current state of this and highlighting all of this work that needs to be done, and hopefully some of us in this room will be the people to do it. So thank you very, very much. All right, another round of applause for Claire. We'll let you get on with the rest of your day. Thanks everyone for sticking around for these last few minutes. We could wrap up this discussion.
Yeah, thank you all so much. I really appreciate the invite, and Bougie, you're too kind as always. But thank you so much for sticking around past time because I went over.